Our final session asks a particular question, which is what is the best way, if you want to improve the health of vulnerable populations, what is the most optimal way to get there? Is it providing solutions that apply to the whole population in such that it's a universal intervention that helps everybody, or targeted interventions focused on the vulnerable in society? So for this session, we have Colin Boyle as our a moderator. I'll just introduce Colin, and then I'll have Colin introduce the speakers. Colin came to us at UCSF from BCG with this incredible background in looking at, in solving problems in the health sector at BCG, and then has been as the Deputy Director of the Institute of Global Health Studies, and has played a phenomenal role in the growth of that institute over the past several years here at UCSF. So we're delighted to get Colin to moderate this with someone who has a perspective both in health and business. Thank you, Colin.
Thanks, everyone. Thank you. So the title of the panel is about the difference between targeted and universal interventions. And coming from the business world, there's always a tension between targeted and universal interventions. One of my former colleagues was famous for drawing a very simple graph which had richness of interaction on one axis and reach on the other. And the reality is there's a trade-off. There's a difference between, for a given amount of resources, what you get having a high touch intervention with a lot of richness, think shopping with a personal shopper, versus something that is affordable for a large-scale population, like buying clothes at Walmart or at a mass store. And so there's this fundamental tension, and that tension shows up in a lot of the debates around expanding access and reaching out to vulnerable populations, because I think the concern is that if we do that, given the resources we have available, as she showed, other resources that are available might be diminished for other interventions and investments we may be making. So our hope, though, is that there are clever ways out of that, to move back the horizon and to explore ways to rethink through preventative policies and rethinking roles of academic medical centers, policy changes and other things, a way to break that tension, break that compromise between richness and reach, and expand the horizon of what's possible to make it possible for us to provide better services to vulnerable populations. To talk about that, we have three wonderful speakers. First, we're going to have Dr. Margot Kushel come up. Margot, please come up. She is the professor of medicine at the Zuckerberg San Francisco General Hospital, and someone who has worked extensively on issues related to homelessness, including being principal investigator for a number of studies exploring different policy approaches that can address homelessness and the health needs of the homeless population.
Thank you. There should be some axiom that says it is never a good idea to speak between Ashish Jha and hors d'oeuvres. And so I seem to have fallen on the wrong side of that. So I apologize. I'm actually not going to use slides and try to keep it a little more interactive and just try to set the stage. So anyone here has noticed homelessness is a problem either in the Bay Area or if you're from Seattle or otherwise? Who here has noticed it? Okay, awesome. Anyone even think we might be having a crisis? All right. For the healthcare providers here, has any one of you who's a healthcare provider ever felt like you were unable to provide what we would normally think of as high-value care to your patient who is experiencing homelessness? You ever feel like you had to admit people for things that your protocol says didn't really need a hospital admission, or kept them longer when your UR nurses were telling you they needed to go? Has that happened to any of the healthcare providers here? Yeah, a few. Okay. So these observations, really starting from the 1980s and 1990s, which was the start of the US's sort of second wave of homelessness that started really again in the 1980s, really fueled a pretty wide body of literature that has in some ways proved the obvious, that people who experience homelessness have worse access to longitudinal ambulatory care, they have terrible healthcare outcomes, they have much higher rates of emergency department use, much higher rates of inpatient hospitalizations. They get admitted to the hospital for things that otherwise people don't need to be admitted for, and once they're admitted, they stay for a long time. So this was like, I would say, like part one of the medical literature on homelessness, sort of said all of this. And part of this started to look at costs. And it noticed, for instance, in a really famous study that looked at VA patients and another similar study that looked at patients receiving Medicaid who either were or were not homeless in New York City, that people who were experiencing homelessness who were admitted to the hospital had about a 33% higher cost than people who were not experiencing homelessness when everything else was adjusted for. And that didn't even take into account the fact that people were admitted to the hospital on lower thresholds. So this realization spurred an interest in reducing the costs of homelessness, and it sort of spurred this interest in like, well, why don't we do something, even if it's expensive, and we'll get the money back. And what happened then was it developed a series of interventions called Housing First, Permanent Supportive Housing, which I will quickly define for you, which many of us, and I will take some blame for this too, in a younger and more naive part of me, in our exuberance said, we're going to do this, and we're going to save money, and therefore we should do it. And so Housing First, Permanent Supportive Housing, is an intervention that is focused on really the highest cost people who experience homelessness. This is really for people who are chronically homeless, homeless for over a year, who have disabling conditions, and really it has been targeted at the smallest group of that folks, the people who are high-cost users or people who use a lot. And just to give you some context, everyone who experiences homelessness, an estimated 10 to 20% of them go on to be chronically homeless, high-cost users. Most people who experience homelessness don't wind up in this group. And permanent supportive housing was really targeted towards the highest cost users of that high-cost group. So today I want to actually make no friends and complicate the narrative a little bit that permanent supportive housing saves money, and maybe raise some questions about that, but also ask, what does it mean when we pin our hopes on an intervention saving money? So permanent supportive housing since 2010 has been the official federal policy response to chronic homelessness. And I will say that I'm a fan, and I was thrilled and am thrilled that this is the official federal response to chronic homelessness. What permanent supportive housing did is mix together a few other models that have been used in other populations, and it basically means that you get subsidized housing. So in most places, your 30% of your income goes to housing, and the rest is paid by some other government, usually governmental body. So 30% of nothing is nothing, or if you get $400 a month, it's $133 a month. It's just 30% of whatever your income is, with on-site or closely linked supportive services. So these are services like healthcare services, case management, social work services, drug treatment, and the like. And Housing First is the new way of saying harm reduction. This is really a harm reduction model, but because harm reduction was very controversial, they were just rebranded it Housing First. And what that means is, unlike what we used to do for people who struggled with homelessness, you were offered housing irrespective of your willingness to take mental health medications, irrespective of your willingness to enter into drug treatment. We basically said, if you're on the streets and you're suffering, come in. And once you're in, we'll try to engage you in these services, but the house is your own, and the house does not depend on your engaging in these other services. So San Francisco was really at the forefront of this movement. The Department of Public Health started to do this in the late 90s, and I wrote one of the first studies looking at the success of permanent supportive housing, because I and many others were sure that as soon as people got into permanent supportive housing, their use of all these expensive healthcare services would go down and we'd save money, and that would be the end. And so we did a study where we basically did a waitlist control study of people who were admitted compared to people who weren't admitted but were otherwise qualified. And what we found is that the people who were in permanent supportive housing, use of expensive services decreased by a third within the first year and a half. Unfortunately, or fortunately, the people who were waitlisted who were not housed, use decreased by about a third. And they were not different. The slopes were completely overlapping. And we can talk about the reasons for that. But I will tell you that that study came out, and people conveniently neglected to look at the control group. And there were a whole bunch of stories. I was in the shower one morning and listening to NPR, hearing about how this great new program reduces use of the emergency department and inpatient hospitalization by a third. And I'm like, oh, I recognize that paper. I wrote that paper, and that's not what that paper said. And they didn't interview me. But that study really, and others, really got people really excited. And Million Dollar Murray came out in the New Yorker, and there was sort of this big, the Atlantic started writing every other month. The Atlantic was writing about how we can save money on people who are homeless if we just do this. Since then, there have been a spate of really high quality studies, including a 5-city randomized controlled trial in Canada, which randomized thousands of people. A recent study that did sort of a case mix control all the well-done studies show the same thing, which is that in the very small group of people, at the very, very highest users, you probably can offset the cost. You don't save money, but you can offset the cost. And those costs are mostly offset by reductions in inpatient psychiatric hospitalizations, which is something that probably is more amenable to treatment than reducing hospitalizations in someone who has an ejection fraction of 10%, who probably needs to be hospitalized when they fall out of favor. And so those studies show that the small group of people, you can get cost offsets. In nobody can you really save money. And in everyone else, it costs a very reasonable amount for what has been an incredibly successful intervention at its primary goal. Meaning that this intervention was for people who people used to say didn't want to be housed, couldn't be housed, the most difficult, polymorbid group of people, and it found that 65 to 85% sustained long-standing housing, where the control group's 20% wound up with long-standing housing. So that is a remarkable achievement, but it didn't save money. And I just want to push back a little bit, and a few of us in the homelessness field wrote an editorial in the New England Journal last year about this, to actually push back on this narrative that we do permanent supportive housing because it saves money. Because I want to point out to you that nothing we do in healthcare saves money. Erin Carroll, I don't actually get everything I know from the social media, but I do from the New York Times. And Erin Carroll, about 2 weeks ago in the Upshot, reminded everyone that other than childhood vaccinations and counseling adults about low-dose aspirin, there is nothing we do in healthcare that actually saves money. But why is it, when the population is made up of people who are the most highly marginalized people, people who have substance use problems, mental illness, other problems that are highly stigmatized. I don't think it will be shocking to anyone that because of housing discrimination and racial discrimination in education and housing laws and criminal justice, that African Americans are overrepresented in people experiencing homelessness by 3 to 4, that when we're talking about the most marginalized people, we suddenly want to only do things if it saves money, and we ignore the evidence that it does. And I think then we leave ourselves with a really complicated problem of, I could probably design for you a permanent supportive housing strategy that offset all of the costs, but we would house 10% of the 10% of people experiencing homelessness who are the most sick. And probably in that 1% of people who experience homelessness, you could offset costs, but otherwise you couldn't. But I can also tell you that there is myriad of evidence that when you house people, every other aspect of their life gets better. And Ashish was talking about, one of the trade-offs of universal health care is that you pull money out of other things. You could pull money out of housing if we were actually spending any money on housing. But just to say that we have a choice, if we are going to demand that things save money, we can, but we're going to treat a very small segment of the population. And if instead we're going to talk about value, and we're going to talk about outcomes like housing as an outcome, health as an outcome, housing stability and health that goes with that as an outcome, then we won't save money, but we'll be able to treat a much broader group of people.
Thank you, Margaret. That's a fascinating exploration of an exceptionally targeted intervention that we'll spend a bit of time discussing. The other end of the spectrum is something that has been in the public discourse for quite a while, which is the notion of expanding to universal coverage in the U.S. Through a Medicare for All model. And to present on that, we will have Jim Kahn come up, a man who needs no introduction, but I'll do it anyway. Jim, as all of you know, is the founder of the Global Health Economics Consortium, professor here in the Institute for Health Policy Studies, the man who coined the term geekon, and also not widely known, but actually a quarter finalist in Dancing for the Stars in the 3rd season. So, Jim?
There's actually a guy at my club, at my fitness club, who is rumored was a professional football player, but he will not tell us what team. And it turns out that I can torment him by dancing in front of him, and I have threatened to do so until he tells us which team. I have set as my mission for the next 12 minutes to convince you that Medicare for All, also known as single payer, demonstrates that, at least in healthcare financing, the best way to help the neediest is to help everyone. In fact, it is both highly effective and efficient, and in fact saves money. In fact, and the economists in the room, and there are many of you, may push me out of the room because I say this, it is a free lunch. What's wrong with healthcare financing programs targeted to the poor? We have programs that do this, Medicaid, ACA exchange policies with very large subsidies for the near poor, and many, many disease-specific programs. These programs accomplish a lot. They have improved insurance coverage and access, offered substantial financial protection, and are far better than nothing or charity care. However, they do not offer a shared experience. The wealthy have other ways to obtain care. Thus, these programs tend to be underfunded. They may have very narrow eligibility rules, offer low reimbursement to providers, underinsurance, that is high deductibles or copays, and narrow provider networks. This leads to restricted access and quality. Also, they vary and are uncertain over time. This leads to anxiety and coverage gaps. So, truly an imperfect solution for the vulnerable. Oops. I'll master this soon enough. And by having all of these different programs for the poor and many other programs for the not poor, private programs, and so on, we have a multi-payer system that is ineffective and extraordinarily expensive. In this graph, we have life expectancy on the vertical axis and health expenditures per person on the horizontal axis. You see most of the wealthy democracies of the world on the top and toward the left. These lines go from 1970 to 2014, and over that time period you see that these countries have increased their healthcare spending somewhat, and they've also increased their life expectancy substantially. Only in the US, where we have a multi-payer system, have our costs gone out of control without the benefit of the big gains in life expectancy. So let's talk about that inefficiency. What's driving that? Part of it is very high medication prices, 3 to 20 times higher in the United States than in countries around the world. We also have high labor prices and restrictive practice rules that make it hard to provide inexpensive labor for medical care. We have very high use of expensive procedures like MRIs, and extraordinary administrative inefficiency. And I want to talk about that for a moment. Billing and insurance-related inefficiency is huge. This summarizes the results of a synthesis that I and my colleagues did. On the vertical axis, we have billions of dollars per year in the United States, and then the blue bars show how much is expended for this BIR purpose, billing and insurance-related administration, per year. In doctors' offices, about $75 billion a year, hospitals, $74 billion, and so on. About half of these costs are at the provider offices. The other half is at the insurers. In the orange bars, we see the portion that is excess. By comparing what we spend in the United States to what is spent in Canada, which is a single-payer system, we get an estimate of overall how much we're wasting on excess administrative burden. And it works out to about $400 billion per year. This is more than $1 billion per day. It is $1,400 per individual in the United States per year, and is equivalent to all of the health spending in California. So that is a lot of inefficiency. Giving everyone the same great health insurance could improve access and quality of care, but could we realize health gains and afford this kind of a system upgrade? Let's look at the evidence. We have a little empirical evidence and many models for California. Let's start with a definition. What is single payer? So Ashish talked about what Massachusetts did to raise coverage. Massachusetts did not use a single payer system. In single payer, there is a single government or quasi-government payer. We sometimes call it improved Medicare for all. Everyone is covered, like Medicare for seniors, but with simplified and strengthened coverage. Funds come from existing programs plus new taxes that replace private insurance premiums. Eligibility is universal and lifelong. Doctors are entirely in or entirely out, and in practice that means almost all doctors are entirely in. There is a single comprehensive benefits package and a single streamlined billing and payment process, and thus providers deal only with one payer with one set of rules about formulary, reimbursement, what's covered, etc. There is one important historical example of single payer that was started after a multi-payer system was in place, and that is in Taiwan. In 1995, this change happened. The government tracked satisfaction, costs, and health outcomes. Satisfaction initially was about 70%, rising to 80%, which is quite high by Taiwan standards and global standards. This is what they found with costs. Billing-related administrative costs were 1% on the system level and a few percent at providers. This is as compared with 18% in the United States. In terms of watching the cost curve, we see here on the vertical axis is the residual spending growth. This residual spending growth is what's left after you adjust for changing demographics and any disease epidemics and considerations like that. And what was seen was in 1995 you get a peak. That was because people became newly eligible for coverage. And after that, the rate of growth in the residual decreased below what it had been before. So it's an opportunity to control costs. This graph shows the trends in mortality. The top line, the left axis is deaths per 100,000, and the horizontal axis is years. The dark line is the non-amenable causes of death. In other words, causes of death that are not influenced by having access to care. And the gray line below it is amenable causes of death. And what the analysis showed is that there was a flattening of amenable causes until 1995, and subsequently a drop of about 6% per year. The non-amenable causes did not change. There were fewer deaths from circulatory disorders and infections, and notably, the effects were highest among the young and the old and lowest for working age, which precisely followed the coverage changes. In other words, people who got coverage experienced a lower amenable mortality rate. There have been a number of economic studies estimating what it would cost to provide single payer in the United States. Several of these are in the United States, and this is a sample. On the vertical axis, we have the percent of total health spending, and down below we have the different studies starting in 1993. The red bar shows the increase in costs due to higher utilization. Not surprisingly, for each analysis, with an estimate of increased coverage, utilization goes up, and the amount that utilization goes up increases over time as our insurance becomes less and less complete. The blue bars show the savings due to efficiencies in administration and lower prices. As you'll note that the blue bars are in each case higher than the red bar, which means that the system will save money by going to single payer. The last set of bars on the right, California 2017 pollen, is the analysis of SB 562. That's the current single-payer bill in California. SB 562 has comprehensive benefits, initially no long-term care, there's no cost sharing. The bill does not specify financing, but one financing scheme is laid out in an economic analysis that was done by Robert Pollan and his team. It has a sales tax of 2.3%, exempting basic goods and low-income individuals, and a gross receipts tax of 2.3%, exempting small businesses. This is moderately progressive, but less so than other single-payer plans. We built a household cost calculator to take a look at what this would mean, and this is an example of some of our results. For a family of 5, healthy with median income, having a silver level, so pretty strong plan through a job, but paying about $13,000 as part of the premium, under a single payer, that family would not have to pay a premium, of course, and would pay an additional $2,600 in those taxes, with a net savings of $11,000. So that family does pretty well. For a family that got their health insurance through the exchange and got a full premium subsidy, that's the very strong subsidies that the ACA has, they pay nothing in premiums currently, or essentially nothing. They have added taxes and don't do as well under single payer because they've gone to paying some taxes. For a family of four, the same type of family but with many medical problems, they do very well, saving about $1,000. And for a wealthy family at the 95th percentile, those individuals will pay more under single payer because even though they save a lot on their premium, they're paying a $19,000 in additional taxes. That's, again, fairly progressive financing. What about the political feasibility? The current conventional wisdom is that single payer is a political non-starter. Yet polling support is high, about 50%, depending how you ask the question, a little bit more or a little bit less, depending on the wording. SB 562 passed the Senate. It stalled in the Assembly. The holdup in California, there are many factors. Importantly, hospitals and Kaiser are very worried about what this would mean for them. Many of us think it would work well for them, but they're concerned and not supporting. And then there is very pervasive, if often unstated, influence of insurers who really don't want to see this in California. So there's a big political fight ahead. Another issue is that any state single-payer plan would require federal cooperation to work optimally. There'd need to be specific waivers and allowances in various federal programs and laws. So under the current administration, that seems a little bit less likely. So if this resistance to single payer, and thank you for noticing that, a little titter of it. If this resistance to single payer is immutable, then we should give up. But I maintain that we keep being profoundly surprised by the impossible happening. The civil rights movement succeeded. Marriage equality arrived almost overnight after seeming like it never could. And Trump happened. Certainly, I'm not happy about Trump. But if it means that the unexpected can happen, that's an interesting lesson. There are some challenges with single payer. Achieving a reasonable balance of cost control, provider sustainability, and timely access will require careful negotiations on reimbursement rates. And overcoming the American tradition of distrusting government is an important goal. I will note, however, that we distrust government while we insist on our Medicare. Will single payer solve all the health problems of the vulnerable? No, because healthcare access doesn't address economic inequality and other fundamental issues underlying vulnerability. We still will need Margot's housing program. But I think it's a fine start.
Thanks, Jim. I think that's a very provocative discussion and one that will trigger a lot of debate in our discussion later. Now let me invite John Lynn up. John is an internist at Stanford and the VA in Palo Alto. He will be talking about the Polypill. And much as we've talked about some of the challenges in expanding access to universal coverage through single payer and other interventions, there's a question that's similar in complexity around products, commodities, pharmaceuticals in this case, and the notion of what do you give up if you bring many different pills together into one pill in order to simplify access and increase uptake. So with that, John, I'd like to invite you up.
Thank you all. I wanted to thank the organizers for inviting me here and for putting together such an awesome event with so many distinguished professors and researchers to share with us their insights. I unfortunately am neither a professor nor am I very distinguished. I am just finished residency at UCSF, and I'm going to be presenting some of the research that I did here as an internal medicine resident. So, as we know from Kazi's talk, ischemic heart disease and stroke are the leading causes of morbidity and mortality worldwide, and low and middle income countries share the lion's share of the burden. Recognizing this, the WHO around 2011 started releasing different action plans to try to address non-communicable diseases, and they've released a couple, I think, over this time. And the most recent one proposes that we can reduce premature mortality by 25% by 2025. And one of the steps that they propose to getting there is increasing medication prescription for non-communicable diseases to cover 50% of the eligible population. Oh, do I use this instead? Okay. And there was a study that was done not soon after by Yusuf and colleagues looking at several low and middle income countries as well as high income countries. But they looked at how many people who had cardiovascular disease were getting the relevant medications. We know from evidence that people with cardiovascular disease should be on the same 3 or 4 medications. However, we see that in low and middle income countries, many people aren't getting any medications at all. And those that are getting medications are only getting 1 medication, not the 3 or 4 that they should be getting. A number of strategies have been proposed to try to get more cardiovascular medications to the right patients. And one of these is the Polypill. It's a pretty simple concept. Basically, just cram all the pills that you think that the patient should need and put it into 1 pill. This has worked well in diseases such as HIV and TB, and patients enjoy it because they have less pills to take, and it's easier to take. Their adherence is unsurprisingly a lot better. It's also easier to prescribe. As Ashish had mentioned, many providers may not know exactly what they should be prescribing, even if they are able to diagnose correctly. And giving 1 medicine is a lot easier than remembering 3 or 4 to give. The disadvantage is that it's difficult to titrate, and this is a reason why why it faced a lot of resistance in high-income countries like the US, where many providers felt that it was very difficult for them to get the right doses of medications to the patients that they needed. But there was an argument to be made that the Polypill could be very useful in low and middle income countries where patients aren't getting the right medicines anyway. Even if you're not able to achieve the optimal dose, at least getting them something and getting all of these medications to them at once would be a good idea. And so in 2012, there was a group of cardiologists that had submitted an application to the WHO for its model list of essential medicines. This is a list of medicines that the WHO calls a core list of medicines that any health system, basic health system, should provide. But the WHO rejected this application. They said there was no evidence on efficacy, there's no evidence on safety, and there is no evidence on cost effectiveness, which is reasonable. And so since then, there were a couple of randomized controlled trials that were done looking at secondary prevention and the Polypill. And these 2 were called Focus and Umpire. Notably, they did have some patients that were in low and middle income countries. And the evidence shows that these trials were not powered to show outcomes, but they did show improved adherence, and they did show that there was improved blood pressure and LDL cholesterol. And there was also demonstrated safety. So when you looked at people who got the Polypill versus usual care, you weren't seeing a lot more side effects. And so our question was, could we answer the 3rd question the WHO had? Is the Polypill going to be cost effective relative to usual care for secondary prevention of cardiovascular disease in low and middle income countries? And so we looked at 5 countries that we thought represented a good spread of, I guess, the sort of regional characteristics as well as stages of development. And these countries all have a fairly high burden of cardiovascular disease, with the exception of perhaps Nigeria. And there are 2 thoughts about the cost effectiveness of the Polypill. And one of them is that, this is sort of the idealistic hope, is that we can reduce costs associated with acute events. On the flip side, as Kazi had shown in his PowerPoint, the Polypill may actually increase costs, and this may be from increased prescription, basically prescribing a more expensive pill rather than just 1 pill, and also prolonged survival, so people living longer and accruing more healthcare costs that way. So we wanted to answer two questions. The first is looking at the cost effectiveness of the polypill. And what we did here was we said, everybody who is currently getting any medication at all for cardiovascular disease, what if we gave them the polypill instead? Would that be cost effective? The second question that we asked was a different question and less about cost effectiveness and more about what we could do in terms of what we could expect if we try to achieve the WHO goals. So if we could prescribe all of these individual medications to 50% of the eligible population, what would we see in terms of reductions in mortality and reductions in DALYs? What if we did that with the polypill instead? Would we expect greater reductions in DALYs, and if so, how much greater? So we did this with a computer simulation of adults in each of these countries with prior cardiovascular disease. And these are sort of parameters that we use. We looked at the healthcare system, and so we didn't actually look at sort of lost productivity costs and sort of societal costs that could actually make the polypill look a little bit better. And we looked at what the costs, all the costs and health outcomes would be over the entire life of the patients. We looked at several outcomes. First, major adverse cardiac events, such as MI, strokes, and cardiovascular deaths, as well as the disability-adjusted life year, which is the aggregate measure of morbidity and mortality. And we measured medical costs in international dollars, and this is a hypothetical currency that accounts for purchasing power parity. We defined cost-effective as 1 times GDP per capita. So if you could save a life at the cost of GDP per capita, then we would consider that cost-effective. There's problems with that definition, but we thought that this would be a fair starting point. And it's used in many other scenarios. And we measured this with the ICER, which is basically the ratio of the costs, the change in costs over the ratio of the change in what you would expect of the outcomes. In this study, we made a few assumptions about the polypill that distinguished it from current care. And one was that we assumed that there would be increased adherence compared to the individual components. And this is borne out in research from Umpire and Focus and does include some low and middle income countries, although it doesn't include every single country that we looked at. Second, we assumed that doses could be titrated. So this was an issue that a lot of providers had with the polypill, is that it's not as flexible as having multiple medications and multiple levels to play with. We believe that the future of the polypill lies in flexible titration, and we think that a lot of manufacturers are moving to that. We made a couple other assumptions that you could argue against, and one was that the polypill would be as efficacious as its individual components. Now, this may be true, but it may also not be true if it's difficult to titrate, or there are other reasons why you may end up having less efficacy with the polypill. And then the last assumption we made is that the cost would be 100% of the cost of its individual components. In some countries, this is true. In some countries, the polypill is actually more expensive than the individual components. And so in sensitivity analyses, we varied these two assumptions. And we said, what if the polypill is actually less efficacious than the sum of its parts? And what if the cost is actually twice as much as its individual components? So I'm going to orient you to this slide, which is the background on which I'll display the results. The dotted line is the willingness to pay threshold. So this is 1 times GDP per capita in each of these 5 countries. And if you look at the red portion at the top, that's the portion where the intervention would not be cost effective. The blue portion is where it would be cost effective, and the green portion is where it would be cost saving. And so what that means is that the intervention would produce results like fewer MIs or strokes or deaths at cost saving. And so in our base case analysis, we found that giving the polypill compared to usual care, so if anybody is getting cardiovascular medications, if we replace that with the polypill, then it would be cost effective well under these thresholds in all countries. The interesting thing that we also found was that in Mexico and also in South Africa, some of our simulations were cost saving. And so this meant that when we took a look deeper into the data, we found that for these individuals, the reason why it was cost saving was because we were averting expensive MIs and strokes and preventing hospitalizations and cardiac caths and surgeries. Whereas in countries like Nigeria, where there are fewer people who are getting hospitalized and fewer people getting procedures, it's actually not as cost effective, even though it would still be under the threshold. These are the sensitivity analyses that we did, looking at whether or not the polypill would be still cost effective if it cost twice as much, and whether it would still be cost effective if it were not as effective as giving the individual medications separately. And our results were pretty sensitive to this, although we would say that if you increase the cost of the polypill, it's no longer probably cost saving in Mexico or South Africa. The next set of results that I wanted to show you is what we would expect if we increased treatment strategy to 50%. So basically prescribing the polypill, increasing coverage to 50% of the population. I was going to show you ICERs for this and whether or not this was cost effective, but after listening to Joshua Solomon's talk on the pitfalls of modeling, I decided to scrap that. But what we did want to show you was basically what would we expect in terms of, even if, and recognizing that it would be very expensive to increase programmatic costs, what would we expect if we were to achieve the WHO goals? And actually, we probably wouldn't expect as much as we would like. So the y-axis here is actually not going from 0 to 100, it's going from 75% to 100%. So 100%, that's the current, I guess, projected set of dialyses that you would expect. And then in the middle column here, usual care at 50% coverage, this is prescribing the individual medications to 50% of the eligible population. And then the right side is prescribing the polypill to 50% of the eligible population. You actually we don't expect huge decreases in dialyses, even if you increase coverage to 50%. It decreases dialyses by maybe 15% and the most in Nigeria, but in Mexico, not as much. So just to jump ahead here to our conclusions, I think there are a couple of things that insights that I had from this modeling. And one was that the cost effectiveness of the polypill may be better in countries in Mexico with more developed health systems, but that the impact of increasing prescription may actually be greater in countries with less health infrastructure. And so there is a balance between what is cost effective and what would be most impactful for countries. And I guess the last insight that I had from this is that the polypill has been hailed as sort of this panacea for cardiovascular disease in low and middle income countries. But a lot of that has to do with coverage. And I didn't show you this, but just switching people from what they're taking right now to the polypill, while it's cost effective, it doesn't translate into a huge decrease in dialyses. And even increasing prescription coverage to 50% doesn't translate into a huge decrease in dialyses either. And so there's going to have to be a wider set of strategies that will have to be employed if we're to achieve the WHO goals. So I wanted to thank all my collaborators as well as UCSF, residency program, and my current fellowship. Thank you.
Can I invite the panel up to the front here? As I understood from your talk, the effort to provide permanent supported housing to homeless people was very good at getting them to have permanent supportive housing,
Yes.
but not good at getting them to spend less in terms of health system costs overall.
Yeah, I think that's the upshot, despite what most of the newspaper articles and things would tell you. And I don't think that's a problem. I mean, I think this population has both a lot of overuse of some systems, but also a lot of underuse of others. And so, there are many problems with harping too much on this cost savings. There's a state legislator in Hawaii who's a doctor, and God bless him, is trying to get housing covered by the Medicaid system, and recently said, if we don't show that we've saved you money in 2 years, you can cancel the program. And I was like, oh God, that's terrible, because there are a couple of reasons. One is, as I talked about, the only group where you can get significant cost offsets is this very small slice of the population, and it assumes that you can predict who they are, which is more complicated than it would seem. But even if you take it that you could predict who they are, how about all the other people who really need the benefits of permanent supportive housing? And not everybody who's homeless needs permanent supportive housing. Most people who are homeless need just a home. And I really think about the supports, which are where a lot of the cost comes in, as the disability accommodation for people with usually behavioral health disabilities. And, when we talk about making disability accommodations for anything else, we're not looking to save money. We're looking
Right.
to make disability accommodations. But the other problem is the underuse, that, when people actually finally get housed, suddenly you realize that they can't walk, and they could walk if they had their hip replaced. And in the rest of the population, we think that's a really good thing to do. But one hip replacement, and suddenly you've blown all of your cost savings. So it makes me really nervous to predicate this whole argument on cost savings.
Yeah, I think there's a logic to spending money on health for reasons other than saving money on health. But the question I would pose is this something that's the responsibility of the health sector or an academic medical center versus society as a whole?
It's definitely a responsibility of society as a whole, and society has failed miserably at this. People blame all sorts of things on the homelessness crisis since the 80s. They talk about deinstitutionalization, and I say deinstitutionalization was exactly the right thing to do. We actually have a Supreme Court ruling of every bit of ethics in this country that says that people should live in the least restrictive setting that they could. The problem wasn't that we closed the institutions, it was that we didn't provide the supports that people needed. But really, the reason why we have the homelessness crisis in this country is because we've had this massive federal disinvestment in affordable housing that has been very quiet. None of the politicians have spoken about it. And so I actually think one of the main reasons why academic medical centers should make an investment in housing is actually as a statement rather than as a reality. I think that it's really important that we as people interested in health say, we've got nothing. Like, I'm a really good doctor, and I don't know what to do in my 15-minute visit when I'm talking about someone who's living on the streets. Like, both of my hands are tied behind my back, and their homelessness so outweighs anything else that they can do. And I think it's important for academic medical centers to say it as a statement, to make sort of community benefits office investments in housing as a statement. I'm not particularly a big fan in having Medicaid pay for bricks and mortar housing, because I think that takes us down a slippery slope that I don't think we need to go to. But I think we need to talk about what Ashish talked about, is if we spend all of our money on healthcare, we also need to be talking about these other things that probably do more to improve people's health than going to the doctor.
So let's open it up to the audience. Jim, do you want to? You pulled your microphone very close to you there.
Well, I just wanted to say that I built my whole argument on the notion that we could save enough money to cover everyone, and I feel as an economist, I feel good about making that argument. But as a person in medicine, I wish that argument didn't matter, because covering everyone, giving everyone housing,
Right.
and covering everyone with good access to health care is just the right thing to do.
Right. It's the right thing to do, and that's why we should do it.
And that's why we should do it.
Right.
Okay. So a lot of disagreement on the panel.
Crazy that.
Ashish, why don't we go to Ashish first, and then...
I just want to quickly echo Marco's point that, look, there's almost nothing we do in medicine that'll be fun. That saves us money. Childhood vaccination being one of the very few things, and some adult vaccinations. And we don't go around saying we're not going to do that, because I think the notion of trying to get savings out of it is insane. It's the wrong frame. If you want to save money, just deny people health care. That's what I would say.
Right. I
We
mean,
don't do that because that's bad for people.
We do that.
right. Right.
Right.
Right. And
Your point of reframing this away from social determinants will save the system to pay for itself, it's a recipe for failure.
yeah.
Right here.
I want to correct one misstatement. Many HIV prevention interventions save money.
Yeah. Fair enough.
Right down here. This,
Right.
Not many.
Right.
sure.
Out of curiosity, how close was it to being cost effective? When you've ever had to go through the agony of deciding whether you should rent or own, you do the little mortgage calculator in the New York Times and you say, well, it costs me this much to rent, but if I switch it over to buying, And you see with small just changes how it goes up and down. It's like, oh, I should buy. So at what point, like if housing is this expensive and healthcare is this expensive, could it have just changed a little bit to where suddenly it was cost effective, or was it way off?
So I think the main point is, the really important point is that what the politicians are saying and what the newspapers are saying is not cost effective. They're saying cost savings. And that goes to the point that when we talk about most of everything we talk in healthcare, we talk about cost effectiveness. And I think this is a moral and political question about how we treat people who are vulnerable in the society. And as I said, it is no phenomenon that this is affecting people who are desperately poor, who are overwhelmingly more likely to be racial and ethnic minorities and to have two of the most stigmatized diseases that we take care of: mental health disabilities and substance use disabilities, which are the most subsidized. And so for them, the reason I can't tell you what it's cost effective is no one has even done the study to look at quality of life, because it's not even viewed as their life as having quality. So in the smallest group of people, that sort of top 1% of users, who have a high likelihood of an inpatient psychiatric, you can actually offset nearly all of your costs. You can bring it down to like $500 a year of costs, and you've offset the most. But that's a pretty narrow group of people who otherwise would need intensive inpatient psychiatric hospitalization.
Great. Other questions? Right here.
I want to ask you about some conflict of interest in this supported housing model, of which I live in one. And it's a very nice place, maybe 10 years old, subsidized, but it's extremely dangerous. We can't even get in the building. We have to wait to be buzzed in. It's all this, crack pipes on my block. I'm glad my son is away at university, and I'm afraid when he comes home to visit. I mostly avoid it. It's not even safe to check my mail in the daytime. And it seems like poverty is profitable. There's I see quite a conflict of interest between being a landlord and a service provider. They put toxics in my bathroom, and because it was a cheap adhesive, and my son had reactive airways. It was totally dangerous, and we've had some very abusive people work there, and they continue to work there. They has cursed us out, all kind of things. It's I was thinking quite a conflict. I mean, it's a very nice place and it's subsidized, but we're segregated by poverty. We're in the worst neighborhoods. And it can't be the solution, but I mean, I'm happy for affordable housing.
Yeah.
Margot, any comments on that?
I think the points are well taken. I'm not sure I have much to add. It's complicated.
Okay, thank you. Other questions? One right here.
This is for everybody on the panel, but there's a lot of themes of a bunch of interventions, suggestions, and studies throughout the day that people have talked about, and you both raised two good points on housing and then a payment plan or single payer payment plan for healthcare. But as a lot of people in here are scientists or doctors or researchers and so on, and finding that balance between advocacy and research, and I think you touched a good point on that it is purposeful who is marginalized and who is affected by these policies and what's happening in the society. At the same time, it's been echoed throughout the day that we do need data, we do need good research and so on, all this stuff. But for yourselves, how do you see your research while continuing it and doing it, but also representing it? Because you did say your research was used but misrepresented. So how do you see yourselves producing research, representing it, advocating on behalf of it, but while also continuing to do that research? Because for every one of you, there's somebody else that does similar research but doesn't do it for the same purpose or without the same frame.
Yeah, that's a great question, particularly in light of the partisanization of and politicization of research and evidence these days. Jim,
I used to title my talk on single payer "Juggling the Jumbled Jungle of Healthcare Reform," and my point was that everyone talking about healthcare reform has an agenda and is happy to confuse the issue if it helps their case, to misrepresent evidence. And it's a huge ongoing challenge. Even what single payer means, a lot of times people who don't like single payer will start by mischaracterizing what it is, and so then you can't have a coherent conversation about it. So I think it's a real challenge, and for myself, trying to set the record straight in various forms, whether it's academic or letters to the editor or blogs, is at least in the right direction.
I think I am an unabashed advocate for ending homelessness. I think there is no excuse for homelessness in any culture, and there's really no excuse in one as rich as ours. And I think I come that as a doctor who sees the day-to-day physical devastating effects of it. But I think what makes me, why I'm a scientist and not an advocate, is that while I have the global aim of ending homelessness, I'm pretty agnostic of how we get there, and I let the data, and I try to play it as straight as I can, and I let the data give me guidance on how we get there to end homelessness. So I'm not agnostic on ending homelessness, and I'm an advocate for that, but I got into a lot of trouble with advocate colleagues when I published that first study, which showed that it didn't actually save money, and I had people sort of breathing down my throat and people telling me, are you trying to hurt the people you care about, and how can you do this, and how can you do this to us? And I was like, well, I think the data is good. I think it's telling us something that's important, and I'm going to just say what it says. But it was pretty painful at the time. So I do advocate to end homelessness, but I don't have a particular horse in the race of how we get there.
Thanks. John, do you want to add anything?
Yeah, I think like what we did in our research was try to tie our research to something that could be prescriptive from a policy and something that could be pragmatic. And so that's why we looked both at, something pragmatic, not like what the cost effectiveness would be if we could increase prescription rates to 50%, which is kind of like a pie in the sky sort of thing, but what would it look like if we just gave the Polypill instead of these individual medications and just be truthful about the effects. And so being truthful is acknowledging that while it's cost effective, it may not have as big results as we want. And I think sort of being honest is really important as a researcher, but also like having results that you can at least, that can be actionable and can be pragmatic for people.
Any final comments? That was actually an excellent question and a great set of responses to close on. I realize we're kind of out of time here. And I think it highlights the importance of scientific rigor in this increasingly politicized world. This is where health economics and the real world of medicine and policy come together. And I think our panel here has highlighted the importance of being fearless in looking at the data, whether it confirms your bias or challenges it. And I think that's the least we can ask of our scientists, to apply that rigor and then bring that voice out to influence those who make the decisions. Jim, do you want to say anything as to close?
Thanks, everyone, for coming today, and great questions and great listening. And we have another opportunity to chat outside and enjoy a reception. Thank you very much.